Okay, welcome y'all to my presentation that I've titled Autism Spectrum Disorder in the Classroom. Um, as you can see, this is a presentation that's really geared towards those who are working within educational environments. So I'm going to ask you to kind of suspend disbelief if you can, pretend that you are a teacher or some type of educator or professional who's working in a school setting. And particularly, this has been geared towards those who are working within the elementary age group. Um, as such, we're going to cover some of the basics of autism spectrum disorder, including diagnostic criteria, the prevalence rates, the impact of social functioning, symptomology that you're going to tend to encounter. But then we're going to shift focus and we're going to focus on targeted interventions that are really specifically geared towards those that can be done and used effectively within a school setting. So first, as teachers, I always want to stress that teachers are not clinical practitioners who are qualified to make diagnoses of people. It is important, especially with disabilities such as autism, that teachers are familiar with some of the kind of highlight diagnostic criteria so that they're able to initiate helpful discussions and perhaps refer students that they suspect might be experiencing a disability of some kind. But it is not a teacher's responsibility to diagnose a child, nor is it appropriate for a teacher to diagnose a child. So as such, I have not included the entire full detail diagnostic criteria, which can be found in the latest edition of the DSM, but rather I've kind of highlighted out main areas that I think anybody working in a school setting should be able to be somewhat familiar with. First, I just want to note that there are kind of three primary diagnostic criteria that a clinical practitioner would use to diagnose autism. And these are centered around the areas of communication, social skills, and behavior. So you'll notice in the first diagnostic criteria I have listed, it discusses persistent deficits in social communication and social interaction across multiple contexts. And then additionally, restricted, repetitive patterns of behavior, interests, or activities. These can often take the shape of very low skills and ability to initiate play or initiate appropriate interactions with peer or staff, lack of ability to maintain eye contact or follow basic social cues, and then also the restricted repetitive patterns of behavior. Sometimes that can take the shape of stereotypical behaviors that children are doing that are often what they're using to regulate themselves, but can appear very abnormal to those around them who don't really understand the function of those behaviors. That's often referred to as self-stimulating or stimming, but also interests, activities. Again, you'll notice that in the separated diagnostic criteria that says these symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. Obviously, it is important to understand the developmental norms of kids at various ages, especially when you're teaching them in school environments. It is totally normal for a child to be particularly interested in something, say, trains, trucks, sports teams, all sorts of things. We're talking about deficits and restrictions and repetitions that are far beyond that you would encounter with typical peers that you would notice are developmentally appropriate for a given child. And again, teachers are not qualified or responsible for making such diagnoses. So it's important to understand and be familiar with this criteria enough that you can perhaps notice when there's a student that may have some unique needs. You can initiate conversations with other staff in the school and those who might help you to perhaps refer that child for an actual assessment if necessary. And this symptomology for autism is able to be clinically observed and diagnosed anywhere between 12 to 24 months of age at the earliest. So by the time a student is in an elementary school setting, it's possible that they've already been assessed and may have already received an autism spectrum disorder diagnosis, but it's also totally possible that they have not. But by that age, a practitioner who is actually qualified to make that diagnosis would definitely be able to do so. Additionally, there are multiple severity levels that are typically assigned to a diagnosis of autism. Again, this is the responsibility of a clinical practitioner to do so, but I think it is valuable for teachers and educators or other professionals who encounter these children to be familiar with these indicators and the functional consequences of these severity levels, because it helps them to determine how best to serve students who might be living with autism or some other disability. There's also a number of other disabilities or diagnoses which can be difficult to differentiate from autism spectrum disorder. These can include other intellectual disabilities, attention deficit hyperactivity disorder, Rett syndrome, social communication disorder, and some others. A good rule of thumb, I would say, is if there is a child in your class who you suspect might be displaying signs of autism, it's good to first initiate discussion with other staff who serve that child to determine if there are other diagnoses the child has already been given. And again, I will say it one more time, as a teacher, you are not qualified or tasked with determining this diagnosis. Knowing when to initiate these discussions and perhaps refer a child to a clinical practitioner is important, but that is the extent to which you need to be familiar with this information. So when discussing the prevalence rates of autism spectrum disorder, I think it's really illustrative to first note the increase at which we've been able to understand and identify children who have autism. So in 1992, about 1 in every 150 children were diagnosed with autism spectrum disorder. By 2014, that had gone up to 1 in every 68. Additionally, between 1996 and 2005, American classrooms saw a threefold increase in the percentage of school-age children that had autism spectrum disorder that were served in their schools. As you can see from these types of numbers, on one hand, it is possible that autism is becoming more common, but more likely it is that our understanding of autism has evolved to the point that we're able to identify it more quickly, more keenly, and we're able to identify some of the nuances along students that are kind of along that spectrum. That's part of why we refer to it as a spectrum, as opposed to the several different autism diagnoses that existed in previous editions of the DSM. Additionally, autism spectrum disorder tends to be diagnosed about 4 times more often in males than in females. So again, there are complicating factors that contribute to why that number appears the way it does, but it is important just to understand that as a teacher, you might notice some of the symptomology and the things that we're going to discuss later. You might notice that more in your male kiddos than in your female kiddos. So naturally, with any student with any form of disability, it's likely that they will face challenges in their social and academic functioning. While this is not exclusive to children with autism, we tend to see that the primary functional impacts of autism can be identified in 2 primary relationships, those with peers and those with staff. In the classroom, some of the key areas in which a student with autism might be impacted include communicating and understanding peers or communicating with and understanding peers and their teacher, planning and organizing throughout the school day, coping with some of the ordinary schedule changes that inevitably occur, academic skill development as a result of some of these social and communication deficits, also participation in classroom activities, especially those that include larger groups or that tend to involve a lot of sensory stimulation. However, it is important to reinforce that any child, with or without a disability, in a classroom who is engaging in challenging behaviors is likely doing so because they lack fully developed cognitive and communicative skills that they are trying to use to get a need met. There are no bad children. There are no perfect disciplinary practices which can punish bad out of children either. Challenging behaviors are opportunities for us to develop vital skills in children that help them to meet their own needs as they continue to develop into adulthood. In the case of children with autism, it should be further noted that the functional elements of their disability, while they can be managed and developed over time, are simply beyond their control. As such, I want to unpack some of the common discourse around the causes of autism itself. So we've all heard autism is caused by complications as a result of vaccination. Um, there are theories that it is caused by genetic factors, that diet and environmental factors in early childhood development, or prenatal factors such as choices or behaviors of the mother during fetal development are what contribute to the causes of autism. The truth is, the precise factors which research has established predispose a child to autism spectrum disorder are not fully understood. Um, Even so, it is important that we reinforce an understanding and dialogue around autism which is reflective of the best scientific evidence, and to do so gently and with perspective. So, for example, the best scientific evidence that we have right now does seem to indicate that there is some genetic factors that predispose children to autism. Um, that scientific evidence also indicate that this is something that children are born with. It is not something that they develop over time as a result of some particular environmental or dietary factor, or something that's going on during their early childhood development. Um, the other thing that we can say is that the argument that vaccination is a cause of autism is just simply false. It is not based on sound science, and the consensus of the scientific community is that that is not true. So it is important to understand that you're likely to encounter other staff or even parents that have varying perspectives on what might have caused a child, especially their own child, to develop autism. Again, it is important to enter these dialogues gently, but to also understand that it is important to always be communicating information that is truthful to your best understanding and is based on the best scientific evidence. So, scientific research over decades has helped us to understand that in the classroom, targeted interventions are what work to address the unique needs of students, especially those with autism or other forms of disability. These targeted interventions are most likely to take shape in one of four ways: instructional interventions, functional interventions, antecedent-based, and strategic reinforcement-based interventions. Examples of instructional-based interventions are social stories. So that would be creating a actual booklet or story that helps a child to prepare for a common occurrence that might be challenging for them. So you can create social stories around anything. It can be about how to behave appropriately during a fire drill. It can be about how to appropriately initiate a play session with a peer. This is one of the most commonly used and one of the most effective ways of using an instructional intervention with a child who has a disability. Additionally, visual aids on student desks have been shown to be very helpful. So perhaps a visual aid that shows the student, this is what being ready to learn looks like. This is what raising my hand appropriately looks like. This is what lining up appropriately looks like. Visual aids and social stories are kind of the bread and butter of school setting interventions for children with autism. Examples of functional-based intervention that research has shown to be effective involve teaching students socially appropriate behaviors that can serve the same purpose and replace challenging behaviors. So again, that word function. What is the function that a behavior serves? If you notice that a student is often having aggressive or challenging behavioral outbursts around a particular curriculum or around a particular subject, perhaps later you find out that once that student is removed from the classroom, they're beginning to get one-on-one attention around that same academic content, and they are doing so well and appropriately. You can work to teach the student more appropriate ways of serving that same purpose. So you can say, I want you to sit quietly while I give my directions to the entire class, and then I will always devote the first 5 minutes of class to giving you one-on-one attention, and I'll have other students work on their own until that 5 minutes is up and before I will help them. So that gives a student an opportunity to understand that they don't have to engage in the challenging behavior in order to serve the purpose. They can learn new appropriate ways of behavior that can replace those challenging behaviors. Antecedent-based and strategic reinforcement-based interventions are founded around the concepts of behaviorism. So it's about what is the immediate context of the behavior. Also, what reinforcements are taking place after a behavior is chosen. So an antecedent-based intervention might be identifying the key times of day or the key situations in which challenging behavior tends to occur, and then changing that context. It can even be as simple as providing a student with access to a preferred item or activity just before an activity that tends to be very challenging for them. Strategic reinforcement tends to look like the use of edible or tangible rewards when students are engaged in appropriate behaviors, using a sticker chart to track student behavior. This doesn't even have to be isolated to students with special needs. These can be classroom-wide interventions that have been shown to be very beneficial for students at all functional levels. More recent literature has also found that video modeling is a promising method of behavioral intervention for students with autism. Video modeling can be especially helpful when addressing targeted areas of need, such as social and play initiation, building conversational skills, greeting peers and staff, perspective taking, adaptive and functional skills, brushing teeth, washing hands, using the bathroom appropriately. These are all things that video modeling can be used to develop skills in. However, not all skills or behaviors are appropriate for video modeling. A good rule of thumb for determining whether video modeling might be beneficial is to first determine if the primary skill you are aiming to develop is internal versus external. For example, if a student struggles with reading comprehension or vocabulary, perhaps identifying their own current emotional regulation, these skills primarily involve internal thought processes which are not easily observed or reproduced through a video. Thus, they would not be good times to use a video modeling intervention. However, if you're talking about creating a video that shows a student, this is what it looks like to appropriately line up and walk in line. This is what it looks like to initiate a play session with a peer. This is what it looks like to do any given activity that would be socially appropriate and expected in a school environment. Video modeling has been shown to be a very promising intervention, especially for students with autism spectrum disorder. So that concludes the information I wanted to present to everyone. Now you're going to have a chance to test your knowledge if you'd like. You can use this link to find a Kahoot quiz that I created, and you can use the code that's listed here to take the quiz, test what you've learned, test what you've taken in, test what you can remember. And if everybody in the class does it, it could be interesting because we can check the leaderboard at the end of the school year and figure out who learned the most. Thank you very much. This is going to conclude my presentation on autism spectrum disorder. Thank you.